Hello and welcome to another CCSVI Alliance exclusive video presentation. I am Sharon Richardson, President of CCSVI Alliance, and I have multiple sclerosis. The following interview with Ray Crallé, nationally recognized physical therapist, covers the physiology and the rehabilitation of two symptomatic challenges for people with MS, that of gait disturbance and balance. As noted on the Alliance website in its aftercare section, physical activity was one of the long-term strategies we suggested to patients to maximize brain health. We all know there are numerous research studies which validate that physical activity is good for the heart and the brain. Recently, the Washington Post reported on a study from Indiana University. The study suggested impaired blood flow in the legs can actually be reversed by breaking a sitting regimen with 5-minute walking breaks. I was surprised to learn that sitting for just 1 hour, normal blood flow in the legs is impaired by as much as 50%. Another international study published in BMC Neurology Journal found that physical activity and quality of life were highly associated with each other in individuals with MS. Unfortunately, many with MS and other neurological disease have lower motor dysfunction and balance issues, which limits one's ability for physical activity. Hence, there is a reduced blood flow not only in the legs, but the heart and the brain. I pride myself for being physically active, but I do have limitations. I am challenged with balance issues and a weak lower left leg and foot. I was fortunate to meet and have the opportunity to talk with Ray Crallé while at a medical conference in New York. He suggested I come visit his facility. He was confident that he could help me make significant changes in my walking patterns. This spring I made that visit. With repetition of simple and effective therapy strategies, which can be done at home, I gained functional improvement, which has made it possible for me to increase my overall physical activity. My previous experiences with physical therapy concentrated on exercising muscles and moving parts. Ray Crallé, using therapy techniques developed by Margaret Rood and Sir Charles Sherrington, elicited responses through the nervous system. I am pleased that Mr. Crallé was gracious to accept an invitation to discuss the physiology of spastic plantar flexion, incorrectly termed foot drop in many MS patients, vestibular balance, which can have an effect on cerebral blood flow, and the biomechanics of gait disturbance. I hope you find the following video informative and useful to your own prescription of physical activity. My personal advice for anyone who's starting something new, whether it be diet, exercise, any new therapy, realize you have your own unique starting point. Do not measure your success or failure by someone else's experience, because we all have different starting points. You are your own best measurement. The important thing is to do what you can to keep moving. Before starting any type of new physical activity or therapy, please check with your healthcare provider. Links to related research are provided at the end of the video. The following presentation is about 30 minutes in length, so you may want to view it in shorter segments. Please feel free to leave any comments at info@ccsvi.org. Thank you for your continued support of CCSVI Alliance. Physical therapy plays an important part in the rehabilitation and conservation of functional abilities for those with MS and other neurological disease. Today we're here with Ray Crallé from Crallé Physical Therapy in Delray, Florida. I had the opportunity to meet Ray about 1.5 years ago at a medical symposium in New York. And first, Ray, why don't you go ahead, and introduce yourself. Give us a little bit of your background. I think you've mentioned that it's been over 40 years of a lot of experience, and I do want to say that I'm just so impressed with your take on so many, going outside, looking at all kinds of pathologies with MS, neurological disease, traumatic brain injury. You are really keeping up with the research and trying to move forward with the new research. So go ahead and just give us a little bit of background.
Well, my name's Ray Crallé, and I graduated from the University of Iowa graduate program in 1971 as a physical therapist. I've spent 43 years, almost all of those years in private practice. I did do a short stint at a hospital as a staff therapist, but wanted the independence to follow my mind and follow the training and research that I was getting into, and oftentimes that's very difficult to do as an employee in a hospital system. The system will grind you up, and so I became independent of that, and later chaired the private practice section in Florida twice, and was very involved for a short period of time in legislative issues. I was a political action guy in Washington, D.C. when I felt that we could have an influence on government, which I soon learned you can't, particularly during the formation of Medicare rules and all that. But neurologic patients have always been my strong interest. My mother was a physical therapist. She was the 103rd one licensed in the state of Florida when no one even knew what they were. And back in those days, polio was a major concern across the country, and my mother was one of the few therapists treating polio patients. And so as a child, I was actually introduced, and particularly on weekends, my mother would have me in the back of the car as she traveled out into areas of Virginia, evaluating and trying to implement therapy programs at home for children primarily suffering from polio, or infantile paralysis as they called it at the time. So I was exposed to polio, but luckily I guess I was good enough not to have had any type of reaction to that. So neurologic patients have sort of been in my mind for a long period of time, and neurologic patients to me don't only are not only restricted to polio, but also to MS, muscular dystrophy, spinal cord injury, traumatic brain injury, things like that. And so I was heavily influenced by Sherrington, who was won the Nobel Prize in the 1930s, and so Charles Sherrington is a sort of a guru that everyone would know about in the early days, and he was really quite brilliant. He postulated things that far exceeded the technical abilities at that time for him to know about, but he was right on a number of things. So some of Sherrington's early work influenced me, and I found that the pathology that you find in stroke and MS have a lot in common. Even sometimes spinal cord injuries, everyone is accepting that when a spinal cord injury is diagnosed as complete, they accept that like God said so. And oftentimes, while clearly there are complete injuries to the spinal cord and with rapid muscle atrophy, so many times you find spinal cord patients that don't have muscle atrophy, and so they, in my opinion, have, they should be looked at by a therapist that's trained in neurologic approaches. Early on, I was heavily influenced by a number of people that are in the world of physical therapy gurus. Margaret Rood, who developed some treatment protocols based on Sherrington's work. Maggie Knott and others were therapists that were trying to find answers to helping people that had neurologic pathology. So they've all added, there's a number of them, too much to go into, but a number of very responsible therapists whose primary motivation was to help. And so they realized that some of the typical therapeutic approaches were getting nowhere, and basically they were going through the motions, and patients weren't improving, and oftentimes the patients were getting worse. And what I've started to learn is that sometimes the physical therapy can cause patients to not to progress, but some of the therapy techniques and things being done in the neurologic arena are actually causing patients more problems than because they apparently are ignorant of some of the more advanced work of Sherrington and others who did this research so long ago. So,
And I think that would play into some of what we found out about me. Correct?
well, yeah, you were typical of an MS patient. You came in with an AFO, and you know the thing about an AFO, which is a foot drop brace, there are people who have foot drop, and unfortunately, in our world, in the rehab world, foot drop, by definition, is a lower motor neuron problem. Baseball players can get hit with a baseball in the peroneal nerve and have a foot drop, which means you pick up the foot and it drops, and there's no tone or no spasticity, which is very different than a spastic foot. And so the physiology, the neurophysiology going on with a foot drop is very different from a spastic foot. So in your case, in cases of most all MS patients, they have a spastic foot. So the reason for that spastic foot is very different than a passive foot drop. And so an AFO actually, in my opinion, is contraindicated because and it gets into the whole kinetic chain of events related to why the foot is apparently spastically pointing down. And of course, the AFO gives resistance to the muscles that are pushing down on the foot, and that gives the muscles work to do, and so the muscles continue to progress with more and more spasticity. Whereas Sherrington found out a long time ago that we could use sensory stimulation, sensory stimuli, and they included ice and they included vibration, and these sensory inputs were to be applied to the muscles that are related to movement of the foot into dorsiflexion, the peroneal muscles. And muscles, almost all muscles, there's a few exceptions, but for the most part, muscles have a dermatome or a skin map that is related back on the brain. And so Sherrington found out a very important phenomenon. And nerves are divided into basically the diameters of the nerve have an influence on how important the nerve is to function. So a very fat nerve usually is conducting a very important signal. A very thin nerve is conducting a less important signal. So the issue in spastic foot drop, spastic plantar flexion, is how do we get the alpha motor neuron, which is the type of nerve, to let up. And so typical orthopedic approaches is to cut the tendon. Other approaches are to use very poisonous drugs like baclofen or Botoxin, which basically hasn't got anything to do with why the muscle is tight. It's simply a poison that affects the neuromuscular junction, and that I don't think is a healthy thing to do, and it's completely oblivious to why the spasticity is there, because the spasticity is coming from uninhibited information from up in the brain. But Sherrington broke through. He broke through this mystery, and he found that by stimulating C fiber extrareceptors, which are very thin nerves in the skin, and they primarily are like little antennae that send a very weak message compared to the alpha motor neuron. But what Sherrington found out, by using ice over the dermatome of the peroneal nerve, you could summate, which is very important to underline, summate or add up all of the information from these little nerves, these C fiber extrareceptors, and by reducing the skin temperature by 10 degrees, you did two things. You turned off the power, or you turned off the input of the alpha motor neuron in the calf muscle that pushes the foot down, and you activated dorsiflexion of the foot. So to me, it always made a lot of sense to do this, and so in my experience over 43 years, I've had I've thrown away AFOs on stroke patients and MS patients. Now, other types of neuropathology, for instance, ALS is a different pathology, and so they're going to have a legitimate real drop foot because the nerve has been damaged, and so a professional person needs to be involved in making these decisions. Your diagnosis is very important. So, so implementing ice and vibration can cause the muscle to contract. And when we get the muscle to contract, if the physical therapist or a loved one is taught to give resistance to the muscle when it contracts, then you're doing the opposite of what's happening by the brace resisting muscle. You're causing the muscle to have work to do, and you prevent atrophy. And you can actually get patients out of, to have function return in so-called drop foot or spastic plantar flex feet. So the other part of motor learning is that we have to have repetition. You learn to type by repeatedly going through or to use a computer or to do anything where we're trying to motor learn something, whether that even be a sport, hitting a baseball. It's how much you practice that has to relate to how successful you are. So repetition of these techniques is directly related to increased strength and power and the ability for a patient to come back. And in literally every stroke patient I've ever worked with, I've had free from the AFO. Which brings us into another very important part of MS and stroke and other neural pathologies, and that is the effect of the vestibular mechanism, which is our center of balance. So anyone that is working with patients like this recognize, if they're at least observant, that they don't have normal movement of their head when they walk. It becomes extremely obvious once it's pointed out. And so the patients, interestingly, that are trying to pick up the so-called drop foot are not moving their body away from the foot. So if we think about moving a refrigerator, we get up at the top of the refrigerator and we tip it over and we rotate it, and then we tip it over the other way and we rotate it and we walk the refrigerator. But when we look at stroke patients, they usually are unable to move their head, and this is due to vestibular input. It is complicated by other neural input, proprioceptors and the joint sensors and things like that. But by teaching people to move their head, if you lean away from the foot that you're trying to take off the floor, you can't possibly drag it. So people who are talking about their foot being, as an example, in Parkinson's and MS, they'll say that they feel like their feet are glued to the floor, and we all know it's not. But what they're not able to do is move their head. So we like to put patients like that in a chair and seat them, and we start spinning them one way and then the other way to get vestibular input. And then we coach during gait training how to shift your head away from, and you shift your whole body away from the foot that you're trying to get off the ground. And just like the refrigerator, if you tip it over, it can't be on the ground, the edge that you've lifted up. So the same goes with the human body. But again, due to vestibular pathology, the balance centers, the patient doesn't move their head, so we encourage movement of the head to clear the foot to help the patient understand their foot isn't really glued to the ground. Of course, this adds to, and if we do a lot of walking, we get a lot more sensory input into the bottom of the foot. And how many MS patients will tell you, the more I walk, the stiffer I get? Mm-hmm. Well, the more they walk, the stiffer they get. Well, why do they get stiff? Well, you can put more sensory information into the bottom of the foot. And let's think a little bit about the skin on the bottom of the foot. The skin on the bottom of the foot has an awful lot in common with the skin in the palm of the hand. There's just millions and millions of sensory information in the palm of your hand compared to the back of your hand. The back of your hand is fairly stupid compared to the nervous information on the palm of the hand. The bottom of the foot is the same way. The bottom of the foot is responsible for finding out an awful lot of information. Is it sharp? Is it hot? Is it cold? Is it slippery? Is it all that information comes through sensory nerves in the bottom of the foot. Comparing those nerves to the top of the foot, there's a huge difference. And so the impact of that information going into the brain as the brain tries to recover from neuropathology, the information coming from those skin sources is overwhelming. And that's why an adequate neurotherapist needs to understand that. Most of them do. And so what we're doing with the use of ice, which is a very powerful stimulant, if I stick ice in your back in the dark room, you jump out of your skin. It doesn't hurt anything, but it's a powerful stimulant. And so we use the ice over the dumb areas of skin to help counteract the sensory input that's coming from the very smart areas. And so over time, we find that we get fairly normal dorsiflexion back in MS patients. MS patients who can't bend their knee and things like that, they find that they will interpret the use of ice and vibration. And Sharon, somewhere we have a paper that we hand out about the nerve pathway or the dermatome and where to apply ice and vibration. And the typical MS patient or the stroke patient will tell you, well, my goodness, it took all the heaviness out of my leg. We'll also we'll notice increased range of motion, active range of motion by the patient, who, when you ask them at first to try and bend their knee, sometimes MS patients can't do that at all. And you do the ice and vibration on the top of the foot, and all of a sudden they think you're the good Lord because their knee bends. Well, it's simply, it's just simply neurophysiology of being applied to a patient. And so we start getting increased ranges of motion. And of course, then when the patient's lying on their back, we can give resistive exercises into the flexor system. In other words, not only the dorsiflexor, but the knee and hip flexors. And so that is a goal to prevent the atrophy that we know is going to happen. The next thing that happens in a bad way with stroke in MS patients is that they have trunk weakness, and so they have rotation of the trunk. And I often try to relate things in a simple way, and many of us have seen these little toys that you can push the bottom, and the little animal, because of rubber bands, will move or wiggle one way or the other. And so if we're standing with both feet on the ground and we start to rotate our shoulders to the right, then as we do that, the left knee wants to flex and the right knee wants to go back into extension. If I reverse that and I bring my right shoulder forward and twist my body while I'm standing, the left knee wants to lock back and the right knee wants to flex. And so what we find when we have trunk weakness is that this rotation oftentimes is the reason that the patient knee is locking out. It's associated with extensor thrust reflex from the bottom of the foot. However, if we can coach the patient to keep their left shoulder forward, if we've got a left knee that's locking, then it's just simply biomechanical that we've taken control of that knee. By causing the knee to be flexed, we protect the ankle from turning, which is a concern of doctors regarding stroke patients turning their ankle or an MS patient turning their ankle for another reason to give an AFO. So if we're doing competent rehabilitation, we realize that we need to coach the patient to do the trunk rotation to control the back knee, as you might call it, because that protects the ankle from turning, and the whole thing kind of goes together.
Well, I know that since I was here in April and May, spent a few weeks here with you, and then went home, continued with the exercises that you gave to me. And although I had been in physical therapy previous times, there was new things that I was given here to work on, and I think that coming back here, we've seen that there has been some increase or improvement in my gait, and it was hard. I mean, it's hard work. For anybody out there that's listening to you, this is not easy. It's a lot of work, a lot of dedication has to be made.
Well, not only does it help you move better and walk better, but it helps to stop the progress of MS symptoms.
Well, we can go into that just real briefly if you want to. Again, using me as an example with the with my gait, that I was having pain in the left side, and it was with the hip hiking.
Well, going back to the type of gait that you were using, when we don't learn to shift our head away from the foot that we're going to try and take off the ground, which if you watch people walk, if you slow down and walk very deliberately, you have to shift your weight more side to side because you're being required to balance a little longer on the weight-bearing side in order to take the control step with the leg that you wish to move. MS patients can't balance very well because this vestibular input is what's been affected, and why spinning in the chair is
Well,
the
and
way
we
to,
also have a weakness on a side, so we want to get off of that side
Yeah.
as soon as we can.
But you know what? If we take people that have lost their legs, veterans,
This is yeah.
and they have, not only do they not have weakness, they don't have legs, and we teach them to walk by movement of the head. By shifting the head side to side, we teach them how to get their foot off the ground. So weakness is important, and weakness is a reason why people get into these abnormal gaits. But most physical therapists don't seem to be picking this up for some reason.
Mm-hmm.
And I don't mean to bust my colleagues, because believe me, there's some wonderful PTs out there. But maybe it's just the patients that I'm seeing that haven't had adequate treatment or adequate intervention. But in your case, Sharon, one of the interesting things was, and an issue about MS, and is that the problem is about a dislocation at the high level of the cervical skull juncture, and there's some brilliant people, Dr. Raymond Damadian being one of them, who's come out with some pretty interesting information, which I think he probably will win a Nobel again because of his discovery with this, and I'm in awe of his work. And there's a Dr. Scott Rosa who also has been very effective in gentle manipulation of the cervical spine. But the real question is, well, why was the high cervical vertebrae going out, if you will? That's a layman's term. But, well, to me, watching how you were walking, and it's consistent with an awful lot of people, stroke and MS, that they hike their hip. And of course, there's muscles that come off the crest of the ilium, or the top of the hip bone, and they go all the way up to the base of the skull. And so when I'm watching you walk in the hip hiking, you are putting an outrageous amount of demand on the muscles as they attach to the neck. And so by teaching you, by increasing, getting these flexor muscles turned on by using ice and vibration and resistive exercises, we could get you into a more normal gait. And so if I recall, you've had some long period of time of left shoulder pain, and of course the left side of your neck was always something that was painful. And so we changed the biomechanics of how that was walking. And so I'm going to predict, as by the changes that we've created, that through your hard work, your dedication to the exercises and things, that you've actually changed how you walk, and of course you've taken the heat off your neck. And that's my view of how that pathology got started to begin with. And so I would need to have, 100 more patients like you to make a statement. But in your case, it was obvious to me that this was probably why the neck was going dislocating, if you will, according to Dr. Rosa. And I know on imaging there's other things they found in your cervical spine. But I think we all have problems. None of us are the role model. None of us meet. I think if you took MRIs of my own spine, you'd find all kinds of train wrecks. But so what does it mean? And so sometimes we look at images like this and we jump off the bus, and I know for a long time, based on MRIs alone, people were implementing surgeries for pain that failed, because oftentimes it was the soft tissue, and it's fairly normal for people to have herniated discs and bulging discs, and as a matter of fact, as you age, your water and your discs leave, and we get shorter and stiffer, but it doesn't mean that we have all these terrible, horrible neurologic problems.
Okay, we're going to have to, I know your time is limited here, but I would like to go ahead and, one of the suggestions that you gave to me was you wanted me to go ahead and have a Spect Scan. And I did that early on, beginning of the year here, and it was it was interesting that Dr. Zamboni was using, he had just come out with a new abstract, and it was where he was using the PET and the Spect Scan to image MS patients pre and post angioplasty to see what the improvement in perfusion was on their brain. That that was completely separate. You knew nothing about that research, but you did suggest that I have a Spect Scan. And so would you like to go ahead and could briefly explain to us about what the Spect is? What is it doing? What is it showing?
Well, as an example, I've had patients who come here for different kinds of problems, including stroke. And they've had MRIs and CT scans, which is a natural way of looking at the brain, and those are still required and necessary because they give us a lot of important information. However, we find rather consistently that they don't see everything. So I had a fairly prominent patient that came to me who had suffered a brainstem stroke, and I said, well, you know, at your age, that's a warning, and I would like you to have a triple head Spect scan. And he did, and we found a traumatic brain injury that had not been seen on MRI or CT scan. So that's a good example of the fact that we oftentimes can find things or see things. And my particular interest in SPECT imaging is that a lot of the pathology of MS, stroke, traumatic brain injury, is involved in the micro circulation in the brain. And so astrocytes, which are a type of brain cell, they're not a neuron, but they're a glial cell. There are numbers of glial cells, but the astrocytes actually have these very fine little arteries wrapped right around them, and they have a lot to do with how the brain functions. And so I think a lot of pathologies, including chronic traumatic encephalopathy, which is the effects of multiple blows to the head that are being seen in our NFL, many of the veterans that I've treated with blast brain injury from being around explosive devices that go off have damage in this microvasculature that sets off an inflammatory process in the brain. And so I think one of the early indicators in terms of imaging is SPECT. SPECT is not going to pick up the deep parts of the brain, but the surface area of the brain. We will see things with SPECT, and in your case I wanted to do SPECT imaging because I'm predicting, and we're still waiting the outcomes, but I'm predicting massive changes in the picture that we're going to see, and which to you ought to be motivational, because people don't think that you can reverse brain pathology. And I think by the time we get the information, which has already been done but hasn't been read yet, and I haven't seen the scan, but just from your functional changes and other things, I think that we're going to see some fairly nice changes on SPECT imaging.
Yeah, and we probably should add in here that in the interim here, while I was here at your facility, that I went ahead and I had hyperbaric oxygen treatment, and that is for another discussion on another day at some point. There's a lot that is new in the research of hyperbaric and exciting research.
Well, the Israelis have peer-reviewed published papers on stroke 7 years out, having recoverable brain tissue and increased function and better quality of life, even 7 years out. Concussive brain injuries respond to hyperbarics, and that's been, that's certainly part of one of the things that we do here. There's a book out now, Oxygen in the Brain by Dr. Philip James, which just got published, and I suggest people that really want to have. He's a professor of medicine over in Dundee, Scotland, and because of him there's over 100 hyperbaric chambers for MS in the United Kingdom. He's written this book, and I suggest people that might want to learn about hyperbarics from a professor of medicine who's been very dedicated to gas pressures and that sort of thing. So these are the kind of people that advise the spy planes that are going up into high altitudes, and also divers that are having deep sea divers. And so pressure and gas has a major influence, and so oxygen is the brain needs oxygen badly.
And that is one of the things that we've learned with through the chronic cerebrospinal venous insufficiency. If you don't have the good blood flow, you're not going to have the oxygenation of the blood. And the hyperbaric actually is adding another element to that.
Well, Dr. James brings out an issue, and that is that oxygen, when you breathe it, is attached to the red blood cell, and it's not free to be used in the body. It's the plasma oxygen concentration, which is really the usable part of oxygen, And so gas physics teaches that under pressure, when we pressurize oxygen, we push it and we elevate the plasma oxygen concentration, and that's really the working part of hyperbaric oxygen and how we can get oxygen to tissues that normally wouldn't get them. So even though we think about circulation, but even when we improve circulation sometimes, if we don't have the increase in the oxygen perfusion or the amount of oxygen in the plasma, we don't get as big a hit as we would by just increasing circulation in and of its own.
Exactly. Well, I think we've taken enough time of your today, and thank you very much for joining us. And
Well, I can't wait for you to add to this the next set of SPECT images, if you care to share them, the before and after. Because
yeah, we will. I will be. I didn't want to do that on our website yet because we didn't have the post.
Yeah.
But once we get the post, then we'll get back and
Well, good.
update this. So thank you so much. I appreciate it.
Well, you're welcome.